Good afternoon, and welcome to a special webinar sponsored by the Justice Research and Statistics Association. This webinar is titled Implementing Evidence-Based Practices in Community Corrections. My name is Stephen Haas, and I will be serving as the moderator for the next hour and a half. I am the director of the West Virginia Office of Research and Strategic Planning, which is housed in the state's Criminal Justice Planning Agency, the Division of Justice and Community Services. My office, that is the Office of Research and Strategic Planning, is comprised of two units: the Criminal Justice Statistical Analysis Center for the state, which is partially supported by the Bureau of Justice Statistics, and a more recently established unit called the Justice Center for Evidence-Based Practice. Generally, the objectives of this office, as well as the other two units, are to provide research and statistical information, which we hope helps to foster data-driven or evidence-based decision-making on the part of policymakers, such as the governor and legislature, as well as program and or agency administrators. For me, this webinar really hits home in that in 2009, West Virginia, and more specifically the Division of Justice and Community Services in my office, began a statewide implementation of the Level of Service Case Management Inventory, or the LSCMI, which many of you probably know is the latest version of the LSI series, one of the most widely used and validated risk and needs assessment tools for offender populations. This statewide implementation in West Virginia consists of all criminal justice and juvenile justice agencies, making it rather unique in its scope. This very large-scale effort involves not only the LSCMI, but other related components associated with evidence-based practices, such as trainings on motivational interviewing, core correctional practice, and the use of cognitive behavioral strategies when working with offenders. As a certified master trainer on the LSCMI, my office has been responsible for providing all trainings and established quality assurance standards for the use and application of the LSCMI and its related components, such as MI, throughout the state. All of which relates directly to the topics covered in today's webinar. That is, how to implement such large-scale projects in a quality manner with sufficient fidelity to established principles of effective correctional intervention and sustain adherence to what works over time. So today, we have two outstanding presentations. Both authors present very forward-thinking ideas and approaches for getting evidence-based practices implemented in the field, and they also provide a contemporary look at important issues that impact adherence to best practices. While they both center on critical issues of adherence, or what is also sometimes referred to as fidelity to evidence-based practices, they come from different standpoints. James Bonta will speak to his innovative approach in a province-wide implementation in Canada to build probation officers' capacity to apply various core correctional practices, and in particular, use cognitive behavioral techniques in their work with offenders they supervise in the community. Kimberly Sperber will build on this notion of greater adherence to evidence-based practices, as well as specifically addressing what she describes as the risk dosage issue. That is, how to achieve greater adherence to the risk principle by an understanding of how dosage levels in treatment and supervision should vary by the risk level of the offender. She explores a number of considerations that relate to the notions of dosage, such as what actually constitutes dosage, how can it be quantified, and how dosage how much dosage is enough dosage. By providing guidance for both practitioners and researchers on what is needed for applying and quantifying dosage in relation to the risk principle, Dr. Sperber provides guidance for the field on how greater adherence to key principles of effective intervention can be achieved. It's important to mention that this webinar follows the release of a special issue of Justice Research and Policy on evidence-based practices in community corrections. The series of articles relate to what is needed to better ensure fidelity to evidence-based practices in community corrections and treatment. In addition to the topics you will hear about today, there are articles on best practices in implementing MI, how to develop and validate your own risk and needs tool based on Ohio's experience in developing Ohio's youth assessment system, and the potential for the adoption of a risk and needs tool to create systemic changes in the system, for instance, such as reducing probation and parole revocations. With that said, however, our two presenters in today's webinar include James Bonta, Director of Corrections Research for Public Safety Canada. I'm pretty certain that a vast majority of you are familiar with Dr. Bonta's work over the past few decades. Without question, he and his colleagues are largely responsible for the early works on correctional rehabilitation, which resurrected the field from the nothing works era of the 1970s and the early 1980s. He continues to produce research and develop programmatic approaches to offender rehabilitation, such as STICS, which continue to inform the field on effective rehabilitation strategies. When we think of the risk, need, and responsivity model, I bet most of you think of James Bonta, as well as some of his close colleagues. He is the author, along with Don Andrews, of The Psychology of Criminal Conduct, which is widely adopted by graduate school professors and program developers alike all over North America, the U.S., and other places in the world. The book Psychology of Criminal Conduct is certainly a must-read for everyone interested in understanding the critical components of effective offender rehabilitation programs. We will also hear from Kimberly Sperber, Chief Research Officer for the Talbert House in Cincinnati, Ohio. Dr. Sperber has a long history working as an applied researcher, consultant, and quality assurance evaluator for one of the largest nonprofit treatment providers in the country. Talbert House is a private, nonprofit agency that provides services in corrections, adult behavioral health, youth behavioral health, community care, and housing. Her responsibilities include training staff on best practices, helping staff to operationalize research into practice, measuring program effectiveness, and analyzing outcomes data. Her recent research is focused on two areas: matching treatment dosage to offender risk and addressing opiate addiction within the offender population. Dr. Sperber is also involved in helping her agency to implement, monitor, and respond to continuous quality improvement metrics that assess the agency's performance in terms of process, outcomes, and treatment fidelity. To begin, however, in an effort to provide a backdrop to the two presentations today, I'd like to share with you a quote that gets to the heart of our discussion today, as well as the recently released special issue of Justice Research and Policy. As you can derive from the quote on your screen, a common thread that runs throughout the special issue, as well as the presentations today, is the notion of adherence or fidelity in the delivery of treatment supervision in the community. Previous research tells us a couple things. One, poor adherence to RNR principles leads to less desirable outcomes. And second, that the norm in community-based programs is poor adherence. That is, when programs are measured in terms of quality via the correctional program checklist, the correctional program assessment inventory, or other measures, many programs rate unsatisfactory in performance in relation to RNR principles and evidence-based characteristics of effective programs. Thus, this quote tells us that when programs are implemented poorly and adherence to RNR principles is not achieved, we cannot expect good outcomes. With that said, however, over the past decade, the scientific evidence for what works in community supervision and treatment has grown and is ever present. In fact, we not only know a great deal about what works, but also what does not work. Moreover, we also better understand today what the common barriers to successful implementation are, and are learning more every day about what is necessary to overcome these barriers through the emerging implementation science and research. It is clear that in order for us to maximize reductions in recidivism It's imperative that we address the known barriers to successful implementation, which is the issue of fidelity or how well approaches are implemented. And this requires systematic monitoring and measurement. We know such barriers to include notions as organizational culture and or leadership. In particular, organizational cultures that resist the use of scientific evidence to guide practice. Other barriers include having policies and procedures that run counter to the adherence to RNR principles, staff attitudes and orientation that does not appreciate the importance of treatment and rehabilitation services, poor staff selection and training, and resistance among many entities to involving evaluators in the initial implementation of programs and retaining those evaluators for the monitoring of quality service delivery over time. Many agree, in order to overcome the implementation barriers and achieve greater adherence to evidence-based practices, there is a need for a few things. One, greater use of knowledge and lessons learned in the emerging implementation science among researchers and practitioners, and this includes the drivers of implementation. Doing what is necessary to evolve from thinking about evidence-based programs as an intervention to evidence-based decision-making, and recognizing the unique role and necessity of researchers and evaluators' involvement for assessing performance and maintaining quality over time. In recent years, we have seen an emerging implementation science, which combined with the work that has been done over the years with assessing the quality of correctional programs, provides guidance on how to overcome known barriers to implementation. Again, as seen in this figure from Thixon and his colleagues in 2005, drivers for successful implementation include such factors as staff selection. That is, who and what methods are used for recruitment and selection of staff. Pre-service and in-service training, something James Bonta will be speaking to directly, includes things like key practices and skill development through such trainings. Followed by consultation and coaching, resulting in skill maintenance, fostering behavior change for practitioners, staff evaluation, which is the use and outcomes of staff skills, performance appraisals, providing feedback to managers, and program evaluation, assessing key aspects of overall performance of the organization, and facilitative administration, which is leadership, support processes. Administrators often help to focus efforts, and systems interventions to support work of people in the field via external collaborations. External collaborations could be funding sources, the legislature, services, and providers. However, engaging in a systematic implementation process is particularly important in an evidence-based environment, which has the added challenge of integrating technical skills on a large scale and in real-world correctional environments which are characterized by multiple layers of bureaucracy and limited resources. Adherence to evidence-based practices, or RNR principles, requires staff to engage in evidence-based decision-making, which has its own set of demands. In effect, requiring the transition of supervision officers to what we call change agents. Essential in this transition is staff development on key skills, including teaching staff to utilize key aspects of core correctional practice, cognitive behavioral techniques, MI, and other skills. Both Dr. Bonta and Dr. Sperber will speak to the importance of skill development among staff for building the capacity to engage in evidence-based decision-making. Lastly, in an evidence-based environment, data and analysis is critical to inform practice. The research is clear that reductions in recidivism are greatest when program planners and evaluators are involved in the implementation. In addition, establishing meaningful, relevant measures of practice for the purposes of monitoring quality over time is essential. In particular, it is necessary to establish quality measures of performance which reflect adherence to best practices, rather than simply counting the quantity of activities or services that are delivered. In return, through a process of measurement, we, as a field, can continue to fill gaps in our understanding of what leads to good implementation and what does and does not work under what conditions. So today, Dr. Bonta's and Dr. Sperber's presentations will center on many of the ideas presented above, focusing on different aspects of getting and maintaining quality or fidelity in community corrections. It is now time to introduce our first presenter. Our first presenter is Dr. James Bonta. He will describe his efforts to provide strategic training to probation officers. His efforts are centered on improving the use of cognitive behavioral strategies among community supervision officers. Dr. Bonta provides a great illustration of what is necessary to get the skills in the field that are necessary for adhering to RNR principles, placing special emphasis on changing the pro-criminal attitudes of offenders. His approach clearly illustrates the importance of having structured training with coaching and feedback sessions to sustain probation officer skills over time. Before Dr. Bonta begins, I want to make a little programming note. We will be addressing a few questions at the end of each presenter. Those questions will be specific to the presentation that was just heard, and at the end we'll be entertaining general questions that may relate to any of the speakers on the panel. But participants can send their questions at any time. You could just type your question into the question field at the right side of your screen and hit enter. And I'll repeat your question as time allows. I'll try my best to get to all the questions I can, but may not be able to get to all of them due to time constraints. So, without further delay, I'd like to welcome Dr. James Bonta.
Okay, I just have to take a minute to get the presentation up. I hope everyone can hear me fine. First of all, I'd like to thank Stephen Haas and the Justice Research and Statistics Association for organizing this webinar. I also want to note that over the years in developing the STICS model for community supervision, I've been fortunate to have a great many of my research colleagues here in Public Safety Canada and trainers who I wish I could thank each one individually, but because of time I cannot. But I would like to acknowledge everyone's contribution to STICS. What I would like to do is essentially talk to you about our rollout of STICS in the province of British Columbia. However, before I can do that, I'd like to give a little bit of the background to the STICS initiative here in Canada. I think many of you are well aware of the risk-need responsivity principles, which essentially talk about the who, what, and how of treatment. Who do we treat? We try to focus our services, interventions on the higher risk offender. What do we treat? Criminogenic needs, for example, substance abuse. And how do we go about providing these services? It appears that cognitive behavioral types of intervention work best. When we look at the research literature on offender rehabilitation, the evidence is quite clear that following those principles has tremendous payoffs. This chart graph here that I'm showing right now shows that the more closely treatment programs follow the risk-need responsivity principles, the larger the reductions in recidivism. So on the far left, if you have an intervention that completely ignores the RNR principles, you actually have a slight criminogenic effect. If you are able to follow all three principles, you can have significant reductions in recidivism, particularly when they are provided in community settings. We see this same general pattern also with prison-based institutional programs, but the impacts are not quite as dramatic. So I apologize why this keeps popping up on my screen. Anyways, this is quite encouraging results from the offender rehabilitation perspective. However, it's interesting what we find when we go to examining the effectiveness of community supervision. Now, this was a meta-analytic review of the research that we conducted a few years ago. And for example, it will include studies where 6 months of parole supervision are compared to 12 months of parole supervision, or probation is compared to offenders who receive only a fine. The idea here is, does community supervision really make a difference on recidivism? And what our results found was that, well, it seems to have a pretty small impact on recidivism. Okay, so I don't know what happened there because I'm not able to control this. Try again. Okay. So, I don't want to discourage everybody in thinking that, oh my, if I'm a parole or probation officer or an agency responsible for community supervision, the kind of work we do doesn't seem to have much of a payoff. I think the important question is to try to understand, why isn't community supervision more effective than the published research seems to suggest? So a number of years ago, we conducted a study here in Canada that we referred to as the black box study. And it basically was trying to understand what actually goes on within community supervision. What do probation officers do with their clients when that door is closed and it's just the two of them there? Are they following the risk-need responsivity principle? So we went to the province of Manitoba, which is essentially in the middle of our country, and we had approximately 62 probation officers volunteer to open their files to us, and more importantly, to allow us to record their sessions, their supervision sessions with their clients. And of course, we had 3 general questions, all pertaining to the risk-need responsivity principles. So what did we find? Are they following the risk principle? Well, they were following it to some extent, but perhaps not to the extent that we would have liked to have seen. There were just simply too many cases where low-risk offenders were being seen on a fairly and highly regular basis. Were they targeting criminogenic needs? Not in the majority of cases. If the issue was around substance abuse, you could pretty well bet that the probation officer would discuss this with her clients. But some of the other criminogenic needs were not covered as well. And certainly when it came to cognitive behavioral techniques, which ranges from pro-social modeling to cognitive restructuring, this was relatively haphazard. So what we found in that study was that probation officers were following the risk-need responsivity principles to some extent, but the question was, could we help them do better? Follow those principles a little bit more closely. And so we here at Public Safety Canada thought, well, if you were going to design a training program to help probation officers follow the RNR principles, how could we possibly do that? What would it look like? And so what we came up was essentially a two-component training model. First, there was a direct training component that in our original study lasted 3 days. And during that 3 days, it was very hands-on oriented. We focused on teaching the probation officers how to use cognitive behavioral techniques to address criminogenic needs, and in particular, pro-criminal attitudes. Our view was that attitudes often run under all the criminogenic needs. Certainly some attitudes are clearly pro-criminal. For example, when the client says, it's okay to steal, the guy was insured. But you look at how some of the other criminogenic needs, let's say substance abuse. Underlying substance abuse may be the attitude, well, I don't really drink that much. I only get drunk on weekends. Right? That's an attitude. And we felt that if we could help probation officers address those attitudes, they could possibly have a greater influence on the behavior of their clients. We also recognize that, as with so many training programs, you provide training, the participants get all excited, and then within a couple of weeks they forgot everything they learned in training. We thought it was critical to continue the learning of the skills taught in training. And so we have introduced in this model the continued skill development by having monthly meetings where probation officers would get together for a half a day in a structured way to talk about the skills they have learned. They could receive formal clinical feedback from our research and STICS team here in Ottawa. They submit an audio recording and we provide written feedback on what went well, how they can improve their interaction with the clients. And then of course we also provided refresher courses. So our training was set up and we had volunteer probation officers from 3 Canadian provinces come up to the plate to say, okay, we're willing to participate in this study. They came from British Columbia, Saskatchewan, and Prince Edward Island. The probation officers were randomly assigned to receive training or to continue doing the supervision as usual. Everybody was asked to audio record a number of their supervision sessions. So in that first experiment, what did we find? Well, as this table shows, the STICS trained group certainly spent more of their sessions discussing the attitudes expressed by their clients compared to the controls. They also spent more time on the criminogenic needs of their clients rather than on the non-criminogenic needs. So we saw changes in what they talked about. How they addressed these client issues were also in the positive direction. The trained group structured their supervision sessions better, showed better relationship skills, more use of behavioral techniques, and especially cognitive techniques. So our experiment in STICS, the original experiment, showed that the training led to changes in the behavior of the probation officers. The next question is, did it change the behavior of their clients? And what we found was the clients of the STICS POs, probation officers, was almost 15 percentage points lower than the control group. So in summary, the experiment demonstrated a change in officer behavior and reduced client recidivism. Now, the province of British Columbia undertook an exercise in estimating how much money could be saved if all the probation officers in their province were trained in STICS and were applying it properly. And so that was their estimate. The one thing I want to keep in mind here is in our STICS experiment, in the ongoing ones, we focus only on medium to high risk offenders. Low risk offenders in the original experiment was less than 5% of our sample. Okay? So with that cost-saving estimate, the province decided to invest in training their staff in STICS. And this is a cooperative effort between the provincial government in British Columbia, Community Corrections, and the federal government, Public Safety, where I and my team are located. So we had 4 general goals: to train approximately 370 probation officers, build capacity within British Columbia Community Corrections so that they can continue without the support of the federal government. We wanted to make sure that this implementation was done carefully, and throughout the process we wanted to monitor what we were doing and, of course, to evaluate whether or not this large-scale implementation was or is going to be successful. So first of all, with respect to the training, this training began in September 2011, and up till last December, we were approximately 43% of the way through in terms of the number of probation officers to be trained. While all this was going on with 13 offices, there were approximately 13 monthly meetings every single month, except in perhaps the summer. We had delivered approximately 20 refresher courses. So, how did we go about, or how are we going about trying to build capacity? British Columbia has invested resources into creating positions that are dedicated to STICS within the province. We have at the office level coaches who have time set aside to schedule monthly meetings, listen to recordings from their colleagues, and provide feedback. So part of their role is actually to be involved in STICS activities, and their caseload is reduced so they're able to do that. The STICS coordinators, there are 4 of them. They're at a more higher level of sophistication, and they are all full-time probation officers who do nothing but STICS, although they may carry a very, very small caseload to keep their skills up. Both the coaches and the coordinators receive training and special sessions supports from the STICS research team here in Ottawa. The other thing that's important in this BC rollout is that the Community Corrections Division has decided that STICS will be the new way of doing business in the province. And actually in writing, participants in the training receive a letter from the provincial director outlining what's expected of them now that they've been trained. Attend the refresher course, submit 2 recorded sessions for feedback. And of course, together with British Columbia, we work closely in monitoring and evaluating the rollout. Our original plan when we started in September 2011 was a pre-post design evaluation. We asked probation officers that prior to coming to the training, approximately 6 to 8 months before training, they are to submit 4 clients with audio recorded sessions as their baseline. This is for us to get an idea, where do they stand in their skills and what they talk about prior to any training. Then after training, they are expected to recruit 6 clients. They audio record their sessions over a period of 6 to 8 months, and they submit it for research. As we were going along doing the training, in January 2013, we decided to slow down the training schedule. We decided to take what we called a pause to this. So both us in Public Safety Canada and BC Corrections, we both agreed that we need to take a little bit of a breather. And why is that? 2 major triggers for this pause. One was the baselines that probation officers had to provide prior to training was below 70%, which means that we had probation officers coming to training who did not provide baseline recordings. post-training, we had roughly 2/3 submitting recordings. So this became puzzling for us, and we wanted to understand what was happening. But this pause that we took was more than trying to answer the question, why the lower number of projected recordings? But it also gave us a chance to see, are we on the right track? Is there anything promising, any hints that our training and all the monthly clinical supports are having any impact? And we also wanted to find out what was the level of commitment of probation officers to the STICS model. Keep in mind, the original STICS experiment included volunteers. The BC rollout is not voluntary. Everyone is to be trained in it. So we decided to take this time to look at the first 10 officers that were trained, try to interview as many of the staff, ask them to complete questionnaires so that we could get an idea as to what are the problems with submitting recordings. What is the level of commitment to STICS? We wanted to learn from this so we could try to improve the rollout as we continue. We also took a random sample of 92 post-training recordings to give us a little glimpse into whether or not we're seeing behavioral changes in the probation officers. Okay. So first of all, question number 1. Well, we learned a lot of things. You know, the low rate of submission of these recordings was not due to probation officers saying, I hate STICS, I don't want to do it, so I'm not going to participate. We learned that there were offices where there just wasn't the sufficient pool to recruit clients into the study. And we had a little bit of a complicated recruitment protocol where it involved random assignment of clients, and we had to make sure it was done right. So there were difficulties in trying to figure out who does what, how should it be done. And of course, I think it will not come as a surprise to everyone, probation officers vary in their comfort level around the use of computerized technology. It's like for this study, they had to not only get a client to consent to be recorded, but then make sure the recording devices work properly, then upload it onto our special website so it could be sent to us for research analysis. So there were essentially a lot of bugs at the beginning, and it took time to work these out. And what we did find is that during this period, since the pause from January to July, we have seen a sharp increase in the submission of audio recordings. So let's just briefly take a look at the audio recording data. This is a table showing that on pretty well all of our measures, our important measures that are related to STICS, the results are in the direction that we were hoping for. The only non-significant between the control groups and the present rollout training group was on behavioral techniques. That may be because it's an unusual kind of measure that has really picks up a lot on pro-social modeling and the use of reinforcement. And then basically it tells us that probation officers thankfully, are good pro-social models to begin with and use reinforcement techniques relatively well. But at the bottom you can see the trained officers, our small sample, a third of them were using cognitive techniques in their sessions compared to the control where it was less than, well, it was essentially one person who used cognitive techniques. Now, our control group here is taken from the 2007 study. Ideally, we would like to use the baseline from the present rollout, and our plans are to include them, but we just didn't have the time to do all that coding. So just one more slide. That this actually was quite surprising to us. Here we have the control group, the original STICS study from 2007, and the present rollout. And on these various therapeutic measures, we are actually seeing better results than in the 2007 study. Finally, looking at commitment to STICS. We had a number of measures for this, but one of the things I thought I'd show you is we asked them to complete an anonymous survey of what they felt was really useful in the STICS training and the application of STICS. This is on a scale of 1 to 5, with 5 being very useful. So as you can see from this chart, the probation officers by and large find many of the skills taught in STICS to be very useful in their work with offenders. Okay, where are we now? I think this pause that we took for the last 7 months has been enormously important for us. It gave us an understanding of why the recordings weren't coming as quickly as we were projecting. It also gave us a chance to have a breather and to reflect upon how can we improve the rollout for the next half of the probation officers who are getting ready for training. During our interviews, our questionnaires, we asked everyone what they found useful in STICS training, in the monthly meetings, the refresher courses. We asked probation officers how can the managerial leadership offer better support for them in rolling out STICS. And this last point, communicating roles and a vision. This project is interesting because we have a collaboration of 2 independent organizations. We have a provincial, British Columbia agency, and we have a federal agency. 2 different governments. This isn't a project that comes within one agency. It involves 2 governments cooperating, making sure they're communicating who does what properly. But we also have within British Columbia a need to keep the roles and communication channels open and clear. You know, the local manager needs to be clear on what's expected of him or her, coaches, probation officers, the STICS coordinators. There is, in a sense, a lot of hands into the cooking of this pie. So as of today, we are getting ready to resume the training of probation officers. That's going to start in September There's going to be 3 more trainings in the fall, a couple more in the winter. We hope sometime next year to complete the rollout of British Columbia. So this project is really important to us because so many large-scale implementations have not done well. And we hope that this is going to be a tremendous learning opportunity for us and for others on how to go about doing such a large-scale implementation. So I thank everybody very much for their time.
Okay, thank you very much, Dr. Bonta, for sharing your findings and your insights into and your experiences with implementation in your province and in Canada. We do have a couple questions. What I'd like to do is just consider 1, maybe 2 questions now for Dr. Bonta, and then we will move on to Dr. Sperber's presentation. One question that we received is from Michael in Maine. He says, given the rural nature of much of Canada, how do you ensure sustainability of evidence-based practices that require on-site treatment? And I think he's getting at, what are going to be the plans of sustaining and maintaining these skills over time once this project is over?
Well, one of the advantages we see to the STICS model is that we feel that it actually better prepares probation officer to work with a wide range of clients without relying upon referrals to other treatment agencies. In a big city such as Vancouver in British Columbia, it's very easy for a probation officer to be an advocate and a referral person. I can send a guy to addictions counseling or an employment counseling, and that's all I need to do. And there certainly are many rural areas in Canada, and in the situation of British Columbia, in the far north in the interior of the province, probation officers don't have access to treatment programs on a large scale. If they're going to help reduce offender recidivism, they have to work directly with the client. So, STICS can be, I think, powerful for them in terms of empowering them to help with their clients. Now, in British Columbia, they have certainly put aside money where they hired extra probation officers to backfill people who have assumed the coach's role and the STICS coordinator's roles. Those 2 groups, coaches and coordinators, they're in the position to travel to the smaller locations to support the probation officers, run the monthly meetings, and we even have our coordinators now delivering much of the refresher courses themselves. So we're well on the road for sustainability here. I hope that answered your question.
Okay, great. Yes. We'll do one more question. Something that's received a lot of attention, I guess, in recent times has been the HOPE initiative that was started in Hawaii with swift and certain jail sanctions, coupled with treatment and interventions. We have a question from Todd that says, what suggestions do you have for how to successfully link the RNR principles to the swift and certain jail sanctions for violations of conditions of supervision?
Yeah, It's an interesting question. I'm just vaguely familiar with the HOPE program. I guess it started in Hawaii there at the court level. Now, how do you match these things up? And that's really tricky because on one hand, swift and certain punishment, so to speak, can put the treatment provider in a very awkward position. When we do our STICS training, we talk about the dual roles of a probation officer as both, in a sense, an enforcer of the sentence or in managing the sentence, but also being a treatment provider. If my understanding is correct, there's a threat, or there is a very short jail sentence followed by treatment programming. I guess if that's the way it works, then I think it's quite important that within the institution for that short prison sentence, it is properly explained that this is done for certain reasons and we have an expectation that you will continue to engage in treatment programming. In my mind, swift and certain punishment, if it really does work, swift and certain, might work, but I'm not overly optimistic. If we want to reduce offender recidivism, you really need to attend to criminogenic needs. And punishment by itself does nothing to address criminogenic needs. It may suspend somebody from drinking for a couple of days, but that's about it. There's no long-term impact. So in a situation like HOPE, I would really encourage and hope that the treatment providers there try as best as they can to follow the RNR principles in their own way and, in a sense, leave behind the idea of swift punishment.
Okay, thank you very much. All right, so next we will hear from Kim Sperber. Dr. Sperber's presentation centers on the risk dosage issue and how the field can grow through a better understanding of how supervision and treatment dosage should vary by risk level of the offender. In particular, she will discuss how much is enough in terms of dosage when it comes to working with high-risk offenders in the field. She will also shed light on what researchers can do to help better inform the field on this issue of risk dosage. So please welcome Dr. Kimberly Sperber, the Chief Research Officer for the Talbert House in Cincinnati, Ohio.
Thank you. First, I'd like to start by saying hello to everybody who's in attendance and thanking you for your interest in the topics discussed here, and to thank Stephen for the opportunity for us to discuss some of the work we've been doing here at Talbert House on risk and dosage. One of the things I'd like to first note, though, is when we talk about the intersection of science and practice, we typically discuss that in the context of science driving practice. And so those of us who have been on the evidence-based practice road for any length of time have a tendency to think of evidence-based practice in a way where we think of practices that have already been tested in the field and there's research to show that they work prior to us adopting them. And so in that sense, practitioners are recipients of research or science. What I want to bring to the forefront are opportunities for practice to drive science, so that we have a seamless reciprocal feedback loop of science-based practices and practice-based science. I don't think we're likely to see the gap between science and practice to be bridged quickly if we don't get to a system where we have this reciprocal relationship between practitioners and researchers. And I believe the work that we've been doing here on risk and dosage at Talbert House represents an example of such practitioner-driven science where questions from our staff, from practitioners, have helped to shape new research questions as they apply to executing the risk principle in real-world settings. And so while we've been on the evidence-based road for quite some time here at Tower House, and we've been working long and hard to execute the risk principle in an effective manner, I do think it's worth noting what the research says about the risk principle and understanding that at this point in time there is an abundance of research on the risk principle to show support for the risk principle and why it matters. So there are literally hundreds of primary studies at this point in time. There are at least 7 meta-analyses that have been done on the risk principle. And those studies cut across men, women, juveniles, violent offenders, and sex offenders. And so what we know at a very high level about the risk principle is obviously that programs that target higher risk offenders are more effective than those that target lower risk offenders or those programs that target a mixture of risk levels. Reductions in recidivism are greatest for highest risk offenders, which only makes sense. These are the people that have the largest amount of room to improve. Lower risk offenders aren't as likely to reoffend anyway and therefore don't have as much to improve. And probably just as important, if not more important, is the last finding, which is that we now know that intensive interventions can actually harm low risk offenders. And what we mean by harming them is that we actually increase the probability that they will go out and reoffend. And for our line of work, what that means when we harm a low-risk offender is that we potentially inflict harm on the community because they go out and commit new crimes and therefore have no new victims. So research clearly shows that there's a connection between the risk principle and our mission of public safety, which is why it needs to be at the forefront of all the work that we do. These next 2 slides are from a statewide study here in Ohio, and I only put them up to illustrate this point about the difference between how our work impacts high versus low risk folks. This was done in 2002. Our Ohio Department of Rehabilitation and Correction had commissioned a study to be done by the University of Cincinnati on all of our adult halfway houses and CBCFs in the state. They've also since done this study again in 2010. In this first slide, what you see is the recidivism impact on low-risk offenders. And so all of those programs that are represented by the red bars are programs that actually increase the crime rate for low-risk offenders in our state compared to low-risk offenders who got no treatment. The ones in the gray are the ones that actually had a positive impact. And so what you see is that we have only 10 programs having a positive impact on low-risk offenders, while there are 23 that had a negative impact or increased crime rates. And so if you look at that, one interpretation is that those programs in some way, shape, or form, whether it was intentional or not, were helping to produce crime. And when most of us go back and look at our mission statements, nowhere in our language is language about producing crime. It's all about reducing. And so we want to do those things that are more likely to get us to that mission. When you look at our impact on high-risk offenders, you see a reversal in that trend. So we have far more programs now with the gray side having a positive impact on high-risk offenders, and much fewer that are still having a negative impact on those folks. So you see a reversal in the trend with 8 programs still having a negative impact on high-risk offenders, but 27 demonstrating a positive impact. And so I just like that because it's a good visual representation of how important this stuff is, particularly if you take these and put these into raw numbers. In this first study, there were over 13,000 offenders involved in this research, and so if you think about how many of those folks are impacted by the work that we do, it really becomes important. So even if you assume that everybody's on board with the risk principle, and there's no debate that we should be trying to impact our services and the clients that we serve by effective execution of the risk principle, there are still challenges that remain for practitioners who are trying to go down that road. So we understand that we need to provide more services or more supervision for high-risk people and less services and less supervision for low-risk people. But understanding that and operationalizing it are not the same thing. And so what happened here at Tower House probably about 5 years ago is that a number of our staff were coming to us asking what the research said about how much more treatment do we give to high-risk people and how much less to low. Can you quantify that for us? And so when we went to the literature to find out what research was out there, there really wasn't much that spoke to quantifying it in terms of how many hours of treatment, for example. There was plenty of research to show that those who had more intensive services, longer lengths of stay, those kinds of things had better outcome, but there wasn't much out there to say definitively you should be in this range of treatment dosage. And so we found a couple of studies. One was Mark Lipsey's meta-analysis that involved 200 studies of serious juvenile offenders. And I believe the findings there were roughly, they looked at length of stay, and so they found programs that were roughly around 24 weeks seemed to do better than others, and I believe it was on average about 5 hours of treatment a week seemed to produce a positive impact. The more recent study that involved adults was a prison-based study on adult males by Perjean and Armstrong in 2005, and they actually looked at it in terms of different risk categories and looking at different hours of treatment. And so they had several findings. One was that if you were moderate risk with few needs, about 100 hours seemed to produce a positive impact on recidivism. If you were moderate risk with multiple needs or high risk with few needs, you needed about 200 hours of treatment. But if you were high risk and high needs, the group that got 300 hours of treatment did not perform better than their no treatment comparison group. And so it raised questions about how many hours do we need. And from a community-based setting, our concern was this number around 300 hours, was that going to be feasible for us to try to do, and was it even needed in the community? There could be some arguments to be made that community-based settings may not need as high of dosage than prison-based settings. And so that prompted a study here at Tower House that was recently published by myself, Dr. Macarius, and Dr. Latessa, looking at some research we did here in our community-based correctional facility. It's a 100-bed facility for adult male offenders. The sample that we used was almost 700 clients that were successfully discharged in a 3-year period. We did not look at sex offenders in the study. And we did look at dosage defined as number of group hours, and I'm going to come back to that topic because I think the way we define dosage is important. But we looked at just how much time they spent in group treatment. So, for example, we did not count things like case management time. And we didn't count it because at this point in time, we don't use a structured model that ensures that cognitive behavioral teaching technology is being deployed through the case management session, and therefore we chose not to count it. Recidivism was defined as a new sentence to prison, which we thought was the most appropriate measure because at the time the purpose of a CBCF in Ohio was prison diversion. And everybody had to be out of the program for at least 12 months to be in the study for recidivism. These are the results from our first study. And so what we looked at was we broke people into 3 groups of risk, low, moderate, and high. And then we broke them into 3 categories of dosage, also low, moderate, and high. So the low dosage group had 0 to 99 hours of treatment. The moderate dosage group had 100 to 199 hours. And the high dosage group had 200 or more. And so what we look at for the low risk group is you look at when they go from receiving low dosage to moderate dosage, what happens to recidivism. And even with this group, we saw improvements in performance for recidivism. You don't see anybody there with a 200 plus hours for low risk because nobody got that much, or I should say not nobody, but so few that we had to cut them out of the study. So there were literally about 3 or 4 clients who got up in that range. When you look at the moderate risk clients, what you see is they go from, at a low dosage amount, they go at a 52% recidivism rate. They drop to 45% when you go to moderate amount of dosage, and then down to 43% at 200 or more hours. So even for moderate risk clients, when you move from the lowest amount of dosage to the highest amount of dosage, we saw about a 9% reduction in recidivism. It's with the highest risk people that we see the most impact, which is here. And so you're looking at the difference between an 81% recidivism down to 57% when they move from moderate to high in terms of their dosage. Again, we don't have anybody represented over here in low risk because we didn't have high risk people who got low amounts of dosage. And so what we find there is that increasing dosage had an impact for all levels of risk, but they had the greatest impact for high. The one caveat I would like to put in is that our low risk group, while we call them low risk, is actually a mixture of low and low moderates that we collapsed together. And the bulk of the people in that group are actually low moderate risk, and most of them are actually at the upper end of the low moderate scale. So this finding sometimes causes some people some concern because it looks like we're saying we should give a lot of dosage to low risk people. We have a newer study coming out that breaks this out in more detail and will show more definitively that most of that impact is with the low moderate offenders, not with the truly low risk people. So this was a great first step for us in looking at how do we effectively match dosage to risk and how many hours should we be shooting for different risk categories for our staff. But as great as that study was, what we have to be clear about is that at this point in time, there are more unanswered questions about dosage than there are answered questions about dosage. And I'm only going to touch on these briefly because we outline them in more detail in our article. But the first is simply even defining dosage. There is no consistent definition at this point in time in the field about how to count it. We used hours because we felt it was the most accurate and precise way to measure it. But there may be other ways to do it, number of sessions, number of visits, length of stay, etc. What counts as dosage? So as I alluded to earlier, we did not count case management time, and I gave our rationale for that, but others might. We only looked at group treatment. We also only looked at treatment that was aimed at addressing criminogenic needs. We did not count responsivity-oriented activities or treatment. For example, treatment for mental illness would be an example at that time. We also only looked at, we chose a program that we knew had some level of fidelity to evidence-based practice. They use all manualized curricula. They use CBT. And so we wanted to make sure that all those factors were in place before we started counting things as meeting our dosage criteria. What about the prioritization of criminogenic needs? So in other words, does it matter whether we address certain criminogenic needs within our dosage protocols prior to others? So should we be addressing antisocial attitudes, peers, antisocial traits such as impulsivity, poor problem solving, etc., prior to employment, for example? Does that matter? What about counting dosage outside of treatment environments? So far, the research is focusing on pure treatment types of dosage within contained treatment programs. But as we just saw with Dr. Bonta's presentation, there is the opportunity for what probation officers do within their individual visits to count as dosage. So if they're using kind of behavioral techniques and they're showing recidivism reductions through those activities, can that not count as dosage? And that has not yet been studied in terms of trying to quantify that at the probation or parole officer level. We also have issues around the sequencing of dosage and how that moves in and across systems. So within an episode of care, for example, does time versus dosage matter? So, if I give you 200 hours in 5 months versus 5 weeks, for example, how does that differ? The sequencing across the system. So if I am how does that work when we're moving people who might have gotten dosage in prison and now into a halfway house where they might be getting some more dosage, and then out onto some form of supervision post-release where they might be getting something like STICS and getting more dosage? How does that sequencing work, and what's its impact? Related to that would be the cumulative impact of dosage. Many of our people, particularly high-risk people, come to us more than once. Many of you have seen them in your doors more than one time, and we typically refer to them as frequent flyers. What about all that past dosage that they've already received? Does it have an impact? So if you look in the addiction literature, for example, you'll find that there's research to show that people who are suffering from addiction may need 3 to 4, on average, stays in treatment programs before they have any sustained length of sobriety and recovery. And might that be true for high-risk offenders as well? And so we could look at what's the cumulative impact of dosage. What's the impact of the program setting? So it's different to provide dosage in a halfway house versus a CBCF versus some sort of outpatient environment. And we don't know exactly whether that matters or not in terms of how it interacts with dosage. And I think where that becomes more important is in reference to number 8, which are these people who may present to us with low criminogenic risk, meaning that their composite score on something like an LSIR, an ORAS, a COMPASS would suggest that for criminality they're low risk, but they might be high risk for a specific criminogenic need. And typically what we see are people who present with low composite risk for crime, but they are high need for addiction. If we just go on the low risk score, some people may interpret that as we should not give them a lot of treatment. But we don't know that for sure, particularly for people who are struggling with addiction. So maybe I do need 200 or 300 hours of treatment, but the treatment I need is specifically to addiction rather than to criminality. And does that matter in the setting in which I get it, and those types of questions? So all of those things need to be researched. What's the nature of dosage for special populations? We don't know as much about how dosage works, for example, for sex offenders, for domestic violence offenders, for women. The research that's been done so far has primarily been on men. What's the impact of skill acquisition? So as we allude to in the article, we talk about most of the research and evidence-based practices and guidelines that we look at are based on offenders in the aggregate. So if you're trying to apply dosage at the practitioner level, we're applying that to individuals. And so I have an individual client in front of me who might be making progress fairly quickly, and I may have another client in front of me who's not making any progress at all. Should we adjust the dosage based on those kinds of factors, even though they both might be high risk? Right? No different than how a doctor would assess us coming in the door, that if I'm not responding to the medication, they would adjust my medication. If I'm getting well relatively quickly, they may pull back on medication. It's the same type of concept. So rather than giving a flat, everybody who's high risk gets 200 hours, should we be adjusting that based on their individual performance? Are there other types of moderators of the risk-dosage relationship, such as responsivity factors, and how might those play out? So how does mental illness impact the risk-dosage relationship? How might personality type, motivation, those types of things impact the risk-dosage relationship? Are there conditions under which dosage produces minimal or no impact? And so the couple examples we give are, for example, are there saturation effects? So even for high-risk offenders, is there a point at which continuing to give service provides no further impact? Or psychopathic offenders, there's a lot of debate as to whether treatment even works for them. So in terms of all those questions, I just wanted to highlight very quickly some forthcoming studies that are coming out from Talbot House. We have one under review right now, which takes the previous study that I showed you, and we use more refined dosage categories. So rather than having these broad 100-hour groupings, we break them down into 50-hour groupings. So for example, if we say in the first study 200 or more hours for high risk, in the second study we might be able to say, is it 2 to 250, 250 to 3, rather than just looking at that broad 2 to 300 hour range. We have a couple of studies in progress right now, one on women and one on offenders who have been assessed as neurotic through the Justice Inventory, and hope to have those finished and written up in the near future. And then we have several that are under construction in terms of building the data sets. We have one on sex offenders. We have one that will look at the impact of role play within the risk-dosage relationship, and we have one that will look at the impact of client strengths on the risk-dosage relationship. So what do we know? Research clearly demonstrates the need to vary services and supervision by risk. I would argue that at this point there's too much research to debate that finding. We currently have some guidelines to suggest where we should be providing dosage and how much, but we shouldn't misinterpret those to imply, for example, that 200 hours is required to have any impact on high-risk offenders. It's likely that it's 200 hours or so that gives us optimal impact. We're not likely to have a one-size-fits-all protocol, and I think some of the preliminary data we're looking at in some of those projects I've already mentioned are already going to show some of that. We as practitioners have responsibility to tailor interventions at the individual client level to their risk-need profile based on the best available evidence, which includes guidelines around dosage. But that's easier said than done, and I think where I'd like to spend my last few minutes is looking at, from an operational standpoint, what does it mean to try to tailor dosage to risk? And so if we're looking at these kinds of things, for example, obviously we need to have a process to assess risk for all clients. I think that's a given, and most organizations now do that. But beyond that, we have to have modified policies and curricula that allow for variation, and not just allow for it, but direct it, which means if it's a policy and procedure, it's written down. And I'm not being facetious. Many organizations have practices in place, and they will say they have a policy, but when you go and look, nothing's written down to guide staff behavior and more importantly, then to assess staff behavior against what that written policy is supposed to be for fidelity. We need to look at what our infrastructure is and what our resources are. Every environment's different. So, for example, we have a CBCF that sits across from a parking lot from a halfway house. The dosage protocols in those two programs are vastly different. In the CBCF, the men are there for about 4 months. They're locked in. They don't go out to work, and we have more staff on site, and they basically deliver treatment, most days of the week, all day long. You walk across the street to a halfway house where there's more emphasis on employment. We have fewer staff, and we also have men going in and out to work every day. They're not available for dosage, and so trying to get 300 hours of dosage isn't going to be feasible. And so you've got to take a look at what does your infrastructure look like, what are your resources for those kinds of things. And I would say, obviously, the bigger issue, too, is to not get stuck in current operations. Oftentimes when we go to design something new, we start with what we do now, rather than just simply design how it should be and work backwards from how it should be into what you can actually do, regardless of what your current structure looks like right now. Counting dosage. You have to define how your organization is going to do that. So is that hours? Is it sessions? Is it visits? You need to know what it is you're measuring. More importantly, you need to know how you're going to get that data. So, for example, we can do hours because we have start-stop times recorded. We have an automated clinical record for our correctional programs. That's all automated for us. We can run reports. Many programs are still on paper. Many programs don't even use progress notes to track group attendance, things like that. They may at best have paper attendance sheets. So look at how you currently track data and what you would need to be able to do something like this. What is your data collection system? What are the staff responsibilities? So again, if you're a paper system, somebody has to code that data, put it somewhere, run the data, share it with people, things of that nature. So it takes a lot of thinking through for workflow and operations to create something like that in a paper environment versus an automated environment. Quality versus quantity. Do you know the quality of what you're tracking? So again, fidelity to things that are not evidence-based is not something that we would deem to be helpful. So how do you know what staff are doing? Do you have systems in place to monitor the quality? And to do those things, you need a formal CQI or continuous quality improvement mechanism. So again, are there formal procedures to monitor whether clients get appropriate dosage by risk? Do you monitor the quality of that dosage? Do you monitor the outcomes of clients who receive dosage outside of your evidence-based guidelines? So, for example, those low-risk folks who might be heroin addicts, for example, and we deem that we're not going to just give them a few hours of treatment. We will do 200 or 300 hours. Are we tracking them and seeing how they do so that we have that data to create our own data or our own evidence base? You know, not all of the CQI stuff has to rely on large-scale evaluation efforts. Practitioners can collect routine daily data that contributes to the evidence base of our field. And there's research to show that organizations who have their own internal CQI processes do in fact demonstrate lower recidivism rates for their clients. So in closing, what I'd like to conclude is that, you know, we have benefited from a large number of well-established evidence-based guidelines and practices. I mean, if you look at the RNR model, those are some very clear evidence-based guidelines that have been researched for many years and have been shown to be very effective. Within those, there's been a lot of work to operationalize those guidelines into practices such as all the risk assessment tools that now exist, CBT and core correctional practices, and how to deploy those at the line staff level. The next evolution, though, needs to focus on bringing a more nuanced understanding of those guidelines and practices to the individual client level as we treat individual clients, because we don't work in the aggregate in the field, we work at the individual level. And I would argue that practitioner-driven data needs to intersect with research so that we begin to drive the process so that we continually move this field forward to maximize public safety outcomes. Because at the end of the day, that's what it's all about. So regardless of whether you're a practitioner, an administrator, a policymaker, or a researcher, we all share the same goal, and that's producing stronger, safer communities. Thank you.
Thank you very much, Kim, for that presentation. I think you just helped people decide some of their dissertation topics and research agenda for the next few years. Very informative, very detailed. We're getting a lot of different questions right now on this. And I think there is quite a bit to ask. I think one of the questions and a couple actually of the questions relate to really the defining dosage. And people want you to kind of reiterate how you guys define dosage for your study, but also point to the fact that maybe National Institute of Corrections defines it in terms of offenders' time, in terms of both treatment and non-treatment activities. And how would you view that? Should non-treatment activities be considered in dosage? And in your study, how did you handle that?
Sure. So to start with our rationale for how we define dosage in terms of hours, you know, we took a look at that issue. One is we already have a system that calculates it in hours, which was quite handy. But the other thing was if you look at doing it by length of stay or number of sessions, what you don't get to is the variation within those. So you and I could go stay at a halfway house. We could both be there 90 days. It doesn't mean we got the same amount of treatment, particularly in treatment environments where they're truly trying to modify treatment by risk. And so we felt it was a more precise measure. In terms of counting non-treatment activities, in this first few studies were all done in our CBCF. There isn't much to count outside of that because they're not going to work and doing other things. And so we didn't even really have the ability to track things outside of treatment for the most part. In some of our newer studies where we're looking at other environments, those are some of the questions on the table. So I'm not sure what people are calling non-treatment activities, but for example, like education or employment. Employment is clearly a criminogenic need. Employment in and of itself, I wouldn't call that treatment or therapeutic, but it clearly has an impact on folks, and so that's one of the questions on the table. For example, if I'm in a halfway house, maybe I don't need as many hours of traditional treatment because there's a buffering effect from that employment, and there's some value in that, and that also modifies my behavior. But we've not yet tested the relative strength of those things against each other, if that makes sense. And we talk a little bit about that in the article as well. It's a great question. Okay.
Other questions that pop up relate to in terms of defining and measuring dosage, for instance. and I think that you alluded to this quickly in some of your discussion about how is dosage related to skill development. One person is raising the issue of, should we be looking at dosage only or exclusively in hours, or should we be more specific to doing some sort of skill, like you said, skill acquisition, or some other kind of measure to actually, sort of determine whether there's the actual presence or absence of change on the part of the participants.
Yeah, I absolutely think future research needs to incorporate measures of individual skill acquisition of the clients who are participating to see how dosage interacts differently for those folks who are making progress versus those who are not. And we do talk about that in the article as well. And we did not have that data available to us at the time that we did our original studies, but are planning some future studies where we hope to be able to incorporate measures of individual skill acquisition and treatment progress.
Mm-hmm. Has any of your research so far, been able to look at the effects of dosage by the criminogenic needs? I mean, a person who may have certain types of addictions or dependency might require more dosage than people who maybe have poor attitudes or hang out with the wrong groups of people and so forth.
Right. We've not yet. We're hoping to be able to do that in the future. We have just rolled out a new automated clinical record system that we think will be better at capturing some of that. Now, we do have a system or a study in play right now that is on drug of choice, and we'll be looking at the impact of dosage as it pertains to drug of choice. And our particular interest is with opiate addicts, but we have all the drugs coded, and so there may be something that comes out around that specific criminogenic need. But no, we've not done that yet.
Okay. All right. So what I'd like to do now is just kind of open this up so that we can ask Jim or yourself questions about the work that you guys have done. I do see a question in here that relates back to Jim's presentation, and it's asking Dr. Bonta whether dosage was measured in the STICS study, and what the, and if it was measured, how was it measured during your work with STICS?
Well, in the original study, we did not look at dosage. However, in the present British Columbia rollout study, we are collecting this kind of data. We're trying to keep track of people being referred to outside counseling agencies, how many hours they're going to get. And also, the British Columbia Community Corrections has an interesting system which they call nodes. And this could range where they count not only time that there are the face-to-face interactions, but they also count whether they go out to a work setting, whether there's even a telephone contact with the client, so on and so forth. So certainly, Kim has raised a number of really intriguing questions around the dosage. What is it? How do you measure it? And in the present study, we are going to take some time to try to consider these general dosage issues, but we never did it in the original experiment.
Okay. Another question I'd like to get out here. There's a lot of talk, and this question is loosely off of Jennifer's question that was submitted, where she's asking about this notion where we have low-risk offenders who are, for instance, high in need for substance abuse. How does dosage, and even for you, Jim, how would you also see what these programs' role are. Should they be turning away people because they're low risk but high in need for maybe treatment for substance abuse, but low risk in every other way? How does this relate to dosage, and then how would this relate to maybe your thoughts in the work you're doing in Canada? So let's start with Jim first, and then Kim, you can answer that.
Yeah, I'll try to be very brief. We certainly do not say don't treat somebody if they have a real issue that interferes with their quality of life. The problem, of course, is that there's every year seems to be fewer and fewer resources. Caseloads get higher and higher, and it's almost like you need to make a decision as to who I can treat. I cannot treat everybody. In the issue of a drug offender, part of there is depends on your assessment instrument on one hand. So if you have a really serious drug offender, your assessment instrument should be able to move that person into at least a low moderate kind of setting. That makes sense. It's very rare to see a truly low risk offender with a serious drug problem. You may see it once in a while, the lawyer who gets caught sniffing cocaine, but otherwise everything else is okay. But for the more run-of-the-mill substance abuser, they're going to have difficulties in accommodations, in the people they hang around with, so on and so forth. So the truly low risk but high drug need, I think they are really far and few between.
Okay, so that's great. So Kim, from a dosage standpoint, how would you suggest that case managers handle a situation? And I take Jim's point that oftentimes a person who does have a serious dependence or addiction probably has other criminogenic factors. But do you have any thoughts on that from a dosage perspective?
Yeah, I mean, obviously we're at a preliminary stage to be able to truly answer that question, but I think in some respects it's more about the setting in which they get their treatment than an hours question. So what's happening is, so for example, the lawyer who sniffs some cocaine, or what's more common, at least in our area, are the medical professionals who inadvertently get addicted to a painkiller that they got legally to begin with and now are stealing it from work. Is it appropriate to put them in a halfway house to get that treatment that they need for addiction versus putting them in an environment which really is geared primarily towards addiction only and not criminality? So that's my issue. It's not so much about turning people away. It's to look at, if we bring them here, are we likely to help them or hurt them by our environment? So if I'm taking that low-risk person and surrounding them with a lot of higher-risk people for criminality, is that in the long run going to help them or hurt them, even though I know they need help for that addiction? Or is there another way we can accommodate the addiction treatment without bringing them into that environment? Those are some of the questions I think we have to tackle as a system. And it's tough because in some jurisdictions there aren't enough options to say, well, we'll simply send them over here and not take them. We might be the only game in town for that person. But I think we have to be very cognizant of what our environment brings to that person, that individual person's treatment.
And I think that relates directly to the need to get people in the field using evidence-based decisions and working with the people that they have in front of them and weighing that against the resources they have and so forth. So
exactly.
what I'd like to do at this point is just remind everybody that the Justice Research and Policy Journal, the special issue on evidence-based practices in community corrections, is available. It is online. You can go to the JRSA website, jrsa.org. There's a lot of other articles relating to risk and needs assessment, motivational interviewing, and we have a couple very good response pieces from practitioners I think you'll find very enlightening. I want to thank Dr. Kimberly Sperber and Dr. James Bonta for their participation in this webinar. I think it was a great success, and I'm sure that a lot of people have taken a lot of information that they can take back to their work with them. So this is the conclusion of the webinar, and I want to thank Dr. Bonta and Dr. Sperber and everybody else who asked questions and listened in. Thank you very much, and have a good day.